Podiatrists are basically podiatric physicians with we're medical professionals devoted to the study and medical treatment of the disorders of the human foot. We're the only medical professionals who exclusively specialize in the foot and ankle. So if you have a knee problem, I can't help you. All right, so generally, I just want to introduce the diabetic foot. The reason I've put this picture up there is because I think this epitomizes the problem with patients when they've undergone an amputation. Their quality of life, and I know Dr. Mark was talking about quality of life, is greatly rescinded. And in 2005, during World Diabetes Day, we did a lot of work with the government and DMI in trying to make people aware of the diabetic foot complications, because you know your feet are very important. You cannot drive a car if there are no tires. Doesn't matter how good the engine is. It's the same with the feet. If you're not mobile and not able to be biomechanically stable, then what will happen is your quality of life will completely rescind. And diabetic foot problems cause more amputations than any other pathology. All over the world, healthcare systems have failed the diabetic foot. However, amputations are not inevitable. If you recognize the at-risk foot and the prompt institution of preventative measures and the provision of rapid and intensive treatment of foot diabetic complications in a multidisciplinary, and we have to talk about multidisciplinary, no one person can manage the diabetic foot. It takes 500 shillings to teach someone how to manage their foot complications. It takes 30 to 50,000 shillings a day if you end up with a severe diabetic complication and end up in hospital. And patients can't afford it. So we have to get them when they're early. Just a little bit. Now, Dr. Mark talked about 15%, yes. 14 to 20% will need an amputation. One leg is lost every 20 seconds now. That needs to be corrected. And 85% of these are preventable. Most of the ulcers you'll see, 51%, are on the toes to do with motor neuropathy in particular. Plantar metatarsal heads, 28%. Dorsum of the foot, 14%. And multiple ulcers, 7%. 60% of your diabetic ulcers will heal with just good offloading. With no other medication, just good offloading. Okay? Now, if you don't remember anything from my lecture and fall asleep in it, then this is what I really want you to take away. This slide is very, very important, and we teach this slide comprehensively. So, sensory neuropathy results in loss of protective sensation, known as LOPS, which then results in different foot pressures, which then can ulcerate and end up with callus and pre-ulceration. If you debride the callus of a diabetic patient, you decrease the risk of them developing ulceration by 65%. Joint mobility. Most of your diabetics are type 2. They're elderly patients. Their joint mobility is decreased. And because of motor neuropathy as well, they're not able to get down to their toes. 75% of us don't wash our feet. When you're in a shower, do you wash your feet? Do you take the time to go in there and clean between your toes and wash your feet? No, you don't. You let the water run, clean your feet, get out, dry them on the towel, and you go. And this is where the issue is. You need to look after your feet, and it's of paramount importance for diabetics to look after their feet properly. And a simple solution is just get a mirror if they live alone, so they can see the bottom of their feet, because most of these patients are neuropathic. Okay? Motor. What happens with motor neuropathy is you end up with muscle atrophy, in particular the fourth layer of muscles known as the lumbrical muscles. And they're the dorsal muscles of the foot. And what happens is, because they become hypertonic, what happens is they start to claw, and you end up with claw toes. And that then changes the foot pressures as well. That then leads to callus and ulceration. Also, autonomic neuropathy. Ask your patients, have you stopped sweating recently? Because autonomic neuropathy, we have over 250,000 sweat glands in our feet. And these become greatly reduced when you're diabetic and you have autonomic neuropathy. So you stop sweating. So your skin, ask your patients, has your skin become dry recently? And that then leads to fissure, which leads to a porthole for infection to enter, which leads to ulceration, and eventually infection and amputation. Also, one of the things is peripheral arterial disease, which leads to ischemia, poor blood flow, which means that you can't heal. And what eventually happens then is you end up with ulceration, which then leads to amputation. Okay, interdigital maceration in the case of autonomic neuropathy leads to moisture. Again, because you can't clean between your toes and you're not very supple, you end up with moisture between the toes that leads to fungal infections. Okay, so let's just touch on a few of these little things, and I've just broken it down very simply. So neuropathy is the origin of most diabetic foot problems. Okay, 75% of your patients have sensory neuropathy. Okay, there are three types. There's autonomic, motor, and sensory, and these change pressures. Autonomic and motor neuropathy. Again, you stop sweating. You end up with dry skin. So if you see your patients, distension of the veins over the dorsum part of the foot and ankle, all right? Motor neuropathy, okay? Classic signs, okay? High medial arches. When you watch your patients walk into your clinics, watch the way they walk. Because if they walk like this, okay, you can bet your bottom dollar that they have motor neuropathy. And also, a lot of the patients, if they are sort of 40 to 60% neuropathic sensory, then you know how a chameleon walks. You know when you see a chameleon do that on a tree. You'll find your patients will do the same. They'll be very gingerly putting their foot forward because they don't know where their feet are. So they can't detect because of sensory neuropathy. Okay? And prominent leads to clawing of the toes, hammer toes. Okay? Sensory neuropathy. This patient came in because he had painful swollen foot, not because he had a diabetic foot ulcer. We only picked that up when he was actually in the clinic. He did not know that was there. How long was that there for? He has no idea. He had absolutely no idea. And then when we sort of did a neuropathic assessment, we realized that he was about 45 to 50% neuropathic. Okay? And mechanical and chemical traumas can set up the stage for severe infection, which in turn leads to gangrene and even death. Okay? And if you look at a wound like that, like Dr. Ari was saying, when you talk about debridement, you can't clean inside a room unless you open the door. So if you're dealing with an ulcer like that, that ulcer is a lot deeper than you think. So once we probe, and general rule of thumb is if you can probe to bone on a wound, the patient is osteomyelitic. You don't need to go ahead and do all the radiology. If you can probe to bone, you can bet your bottom dollar that patient has osteomyelitis. Okay? And you must get rid of all that thing, so you must open the door so that you can heal that wound. Ischemia. Ischemic results in arterial cirrhosis of the arteries. The best way of describing it is like to take a hose pipe and then put another one inside it and another one inside it. You're narrowing the channel. So this results in a skin that's shiny and without hair. So a very good thing is ask your patients. They used to say, oh, a lot of your patients will tell you, oh, I used to have hair on my feet, I don't anymore. And my skin's become shiny and it's cold to the touch. That is ischemic. Atrophy of the subcutaneous tissue, if you look at all that irritation, it's demarcated. If you look at a foot and you see that the color has changed, that's a risk of ischemia, okay? And basically, you need to deal with ischemia. It doesn't, like Dr. Ari said earlier, it doesn't matter what you put on that wound or if they develop a wound, it will not heal unless you check the vascular status of the patients, okay? Neuropathic foot. Okay, it's warm. The pulses are bounding. Okay, you know, sweating is diminished to do with autonomic neuropathy. There's a cavus foot, a very high arched foot. Ulceration often develops on the sole of the foot. Why? Because the patient has good blood flow. Okay, so if there's callus and you see callus, absolutely, they don't have ischemia. If there's callus there, callus will only form where there's a good supply of blood. And the skin is protecting itself by hyperkeratinizing. Okay? And also, necrosis can develop secondary to severe infection, also known as the Charcot. Remember, you must differentiate between a Charcot's foot and, thank you, and a Charcot's foot and cellulitis, because their management will totally differ. And if you get it wrong, the patient will have devastating consequences. Okay, neuroischemic foot. Enjoy your lunch, I know, but we showed, Dr. Mark showed much more severe. So again, if you can probe to bone, there's osteomyelitis. Well, here you can see it. That patient subsequently had a BKA. Okay, the pulses are cool, okay? May be complicated by swelling, often secondary to cardiac failure. Intermittent claudication. Ask your patients, do you get pain when you walk? Okay? Rest pain. Okay? Even in the presence of neuropathy and high plantar pressure, plantar ulceration is very rare. Why? Poor blood flow. I've just broken it down. Normal, high risk, ulcerated, cellulitic, necrotic, major amputation. We'll just touch on these. At stage 1, there's no factors rendering him or her vulnerable to developing ulcers. These patients should see you yearly. Stage 2 has developed 1 or 2 risk factors and can be divided into the neuropathic or the neuroischemic foot. And there is potential for skin breakdown, as you can see there. That callus has to thing. And also we're talking about other issues, onychomycosis of the nail. Stage 3. These stages you can still manage as an outpatient. Once we get to stage 4, 5, and 6, it's better probably to admit the patients. Skin breakdown, okay? Injuries such as blisters or cuts. And this patient's interesting. This is a patient that Isaac, who will talk to you next, who's a tissue viability nurse, dealt with a pedicure. Again, talking about pedicures. They keep me in business, it's great. Okay, stage 4. Okay, ulcers have developed infection. Cellulitis is present and can be complicated by both the neuropathic and the neuroischemic foot. These patients, you generally need to be hospitalized to make sure you control every single facet of the diabetic complications that they have. Necrosis has supervened. Infection, osteomyelitis, septic arthritis, gangrene. The patient will possibly need an amputation, okay, or extensive debridement. Majorly extensive surgical toilet or surgical debridement. And these patients, basically, you need to review as and when you see fit. The patients before, if you look at stage 2, you need to see them every 4 months. Stage 3, as and when if they've got an ulcer. And stage 6 cannot be salvaged. But interestingly, that foot, that stump healed by, Isaac healed that stump by constant management. And all the other prognosis of that foot was we need to go a higher amputation. And like he said, the salami effect, chopping board effect, by the time you hit that area, you've killed your patient anyway. Microbiological. So basically, a superficial microbiology. Basically, a superficial infection is often that, and a deep infection is often polymicrobial. Okay? Mixed flora. Okay? Generally, when you're dealing with a superficial infection, you debride the dead tissues. Remove the non-viable tissues. Use the time classification, tissue viability, infection control, moisture balance, and epithelial growth. Meticulous wound care. Isaac will talk to you about that. Pressure relief. It's incredibly important. And antibiotics if you need it. How many times do you see a diabetic foot who's been given every single antibiotic under the sun because they have a chronic infection and they are now resistant to everything? Okay? So you need to make sure, and for management of deep infections, hospitalization for surgical intervention, broad spectrum antibiotics, metabolic control. You must bring the other specialists on board and rest as you would a superficial wound. These are just the antibiotics we use quite a lot in the clinical settings. And it's 7 to 10 days for a mild infection, 3 to 4 weeks if it's a severe infection. Basically, wound control has to be there. Microbiological control has to be there. Mechanical control is incredibly important. You must offload off the foot. Vascular control. You must check the vascular status of your patient using the vascular clinics. It's incredibly... Metabolic control. If the blood sugars are not controlled, you will never heal an ulcer. And educational control. I've got 5 minutes left, so I'll be quick. Okay? Educational control is very important. And you must educate the families. That's the key. Conversation maps. Make sure you train the families in how to manage their thing, because out of sight, out of mind, patient gets put in a room, left, and the only time they ever come to the hospital is when the family cannot eat dinner because the smell is so bad. Structural deformities. Again, look at these. Look for calluses, bunions, hammer toes. These all affect the patient's walking patterns and biomechanical gait. And basically, with all of this, nail deformities as well. Other things like this, you know, if you see this can lead to an ingrowing toenail. That can then lead to a severe infection. Okay, changes in the structure of the foot, the forefoot structure, hallux valgus. These are offloading, these are wear. Now, if you end up with a Charcot, you end up with a midfoot collapse or a rocker sole configuration, and you need to offload that. Charcot, you must differentiate between Charcot and cellulitis. It's a neuropathic joint, okay, and it's caused by such an episode as just simple tripping. And because the patient is neuropathic, they often have no pain. They will only come to you when basically the foot is seriously hot and swollen and cellulitic. And then the thing is, they get treated in these outpatient centers for cellulitis, sent to the physiotherapist, get told, go around, mobilize your joint. They come back 3 weeks later, and they've got complete collapsation and multiple fractures in the rear foot. And now you have to, and also Dr. Mark talked about offloading devices. And we're talking about, these are just some samples of the diabetic foot you can see. I just want to talk about 10 seconds on this patient here. He was an ophthalmologist specializing in retinopathy. He basically said he was an ophthalmologist and he specialized in diabetic retinopathy. He didn't think, as a diabetic himself, that the diabetic foot applied to him. That's his foot, bottom left, okay? And that's what happened. He eventually lost that below the knee, because he refused to accept that he had any problems. And as we know, the doctors are the worst patients. Okay, and this is offloading techniques, just simple techniques. This is a total contact cast. Now, with a total contact cast, you have to put this patient in, every 2 weeks you change it. And you keep a rocker sole, and it's manageable with Dynacast, and you can just elaborate a little bit. There's no hard and fast rule to how you do it, but you've got to immobilize the ankle. And you do it for 3 months. This is just a monofilament tester, simple monofilament tester you use and you apply it. It's just, and you can also use the tuning forks as well, and they're very affordable, non-expensive, and you can get them anywhere. Okay, you can also use for temperature, you can use an infrared thermometer, which is great for detecting early Charcot. And with Charcot, it has to be 2 degrees hotter than the collateral foot. So remember, if you get that, start suspecting Charcot. Okay? This is the test sites, they always say, but they keep changing all the time. The guidelines always change. It doesn't really matter as long as you get a rough idea. Okay? This is an ABI exam. An ABI is an ankle brachial index. You measure the foot pressures by the arm pressures, and you get a reading. Okay? It's a fast, effective tool for screening for peripheral vascular disease. We have automated ones now. We have one in MP Shah, we have one at Lions, and basically it takes 10 minutes of the patient's time, and it's not expensive, but it can detect early risk of ulceration and also ischemia. Okay? And these are the values. Oh no, this is Dr. Gammon when he was a lot younger, okay? And actually when I said to him the other day, when I was doing this slide, and someone said, who is that person? Who is that windy man? And I said, that's Dr. Gammon. They said, no, it can't be. You see, he's got more hair, he's a lot more hair then. And that's him performing an ABI, okay? And these are just the general things. So it should cancel itself out, 1. So 8 to 9, mild disease, 5 to 8, moderate disease, 3 to 5, moderate to severe disease, and severe disease is anything below 3. This is just the pulse trace, and this is my last slide. So the aim of managing the diabetic foot is to always keep the patient at as low stage as possible. The multidisciplinary foot team is needed, okay? A foot ulcer is a sign of a systemic disease. Successful management needs the expertise of a team of people. No one person can manage the diabetic foot. These require the diabetologist, the physician, the podiatrist, the surgeon, the nurse, the radiologist, the orthodontist. The orthotist, not the orthodontist. So basically what you need to do is you have to have a team, and we have set up these holistic centers now for diabetes so that we manage the patient as a holistic approach as much as possible. Remember, there's always a more conservative approach to diabetes, or you can go more surgical. Now, not necessarily one's better than the other, but if you manage it as a team, your outcomes for your patients are much better. Thank you very much for listening to me today, guys.
My outline is kind of introduction, diabetic foot ulcer, classification, principles of wound healing, and probably the strategies of diabetic management. Diabetic case presentation, I'm going to give you live feed and way forward. What do we know about diabetes foot globally? Around 415 million people have diabetes, and the number is increasing in every country. And it's estimated that by 2040, we would be having about 642 million people having diabetes. The majority of this increasing number, obviously, is in the developed countries, and Africa, we are not spared. Diabetes is an epidemic in sub-Saharan Africa. And as we have a rise of diabetes, then therefore we also have a parallel rise of diabetic foot complications, because one person has 2 feet. If we have 20 people with diabetes, then you have 40 feet that are in danger. It's one of the major complications of diabetes. Foot problems are a threat to every diabetes person, as we all know. Sorry. Diabetic disease constitutes the most common cause of hospital admission in our diabetic patients. And of course, all this has been said, about 15-20% diabetic will develop a foot ulcer. Diabetics people experience a low limb amputation at a rate of 30% times than the general population, and of course this has all been. But what to take home is, in every 20 seconds, a low limb is lost in diabetes. This is the latest research by Lancet. 20 seconds. I think I've spoken about 30 seconds, so you can imagine how many people have been amputated today. And the beauty of this is that largely these foods are preventable by you and I. The classification that the previous speaker has spoken about is really important. We have to classify our diabetic foot because the underlying cause will be of bearing to managing diabetes. So is that a neuropathic, ischemic, and a neuroischemic, which is just a mixture. And of course, neuroischemia combination, the whole issue there is macrovascular and micro dysfunction, of course, causing impaired perfusion, therefore leading to poor healing of wounds. Neuropathy, of course, they have elaborated on this one so much. I'm going to go through sensory, motor, and autonomic. And the classification, of course, the neuropathic foot has the following characteristics of the features. It's on the pressure point areas, usually surrounded by colors on the peri-wound skin, usually is painless, has adequate blood supply, and the major management there is to debride and offload because on the pressure point areas. The ischemia, again, it's more on the tips of the toes, on the margin and the dorsum. It's usually very painful. It's dry or could be wet. Gangrene time of management is of essence, and the vascular intervention is of value. The neuro is just a mixture of the same, and then we need to involve interdisciplinary team approach in this. The etiology, the underlying cause of diabetic foot will have a significant bearing on the clinical management. It's so we must determine before a care plan is put into place. And those are the photos showing the different characteristics of the etiology. Diabetic foot ulcer result from 2 or more risk factors occurring together. Intrinsic factors, which you have said, an underlying cause, neuropathy, peripheral arterial disease, deformity, triggered by external trauma, poorly fitting footwear, injury to the toes, the colors and the ingrown toes, also fungal, major cause. Like you can see those photos there. The first one is a patient who was immobilized. He was immobile in a renal unit, and they developed decupators, and later it developed an ulcer. Then we have a blister that was caused by ill-fitting shoe, and you can see the end result was an ulcer. And that again, an ill-fitting shoe, and it caused an ulcer, and then you can see the toe, the deformity of the toes, the nails, ingrown toenails and kept nails can also be a major problem in the diabetic foot. Verbida say that we need to keep our patients as low profile as possible. You see the fissures there and the cracks. When you file them off, you will keep the patient as low as possible, as the second picture will indicate. Of course, these are the management plan. We have the education, metabolism, microbiological, vascular, mechanical, and the wound control. I'm going to talk about the wound control, and this requires interdisciplinary team approach concept. Now, the acronym of TIME or DIME is a principal model we can use. T stands for tissue. How viable are the tissues? If the tissue are not viable, we debride of non-viable tissues. Then we control infection and the inflammation. And then we maintain a moist balance, and we look at the wound age effect as we ensure we have adequate blood supply and efficient pressure offload, maintaining tissue repair process. Assessment would help us, evaluation, and reassessment as we give response-directed management. And of course, we need to take full history of the patient and the wound assessment, and we factor in the etiology, the environmental factors, caregiver support, wound aspect, the size, the depth, the location, the condition that may affect healing, like immunological and nutritional status, among the things that provide for us a goal, a diagnosis. And if we have a good, appropriate diagnosis, then we can have a goal of care, factoring the short-term management and the long-term management. Then from there, we are able now to plan for our patient needs. Dr. Mark said that we factor in the patient's needs, very important. Sometimes this patient come in with a wound and then you're feeling the smell. Them, they're not concerned about the smell. They are concerned more about when do I go back to work. So we need to factor in the patient's needs as we plan for their care. And also we monitor the rationale and check for signs of infection frequently, and also reassess, seeing whether the wound is headed to the right direction. And basically that slide is explaining what I've just spoken previously. And I want now to talk about the real case presentation or the real feed. As I said, we apply the time concept of DMED, debride, infection, moisture, and wound age. We are basically doing wound bed preparation, and we are trying to remove all the non-viable tissues, any debris, the bone fragments, and in so doing, we are reducing the bio burden on the wound bed. And then the techniques of debridement are many. Dr. Ball has also elaborated on the same: sharp, mechanical, enzymatic, maggot or larvae, and autolytic. Now, this is one of the cases that this patient was a lady, 60 years old, from Makweni, who was done surgical toilet somewhere, as you see the first picture. And then the post-care failed, and they intended to do an amputation. Then they were referred from thicker level 5 to us, and we were able to follow it up, and we applied the time concept model, and you see as it goes, we were able to achieve a healing after 4 months. And the patient had go home smiling. Now, this is another ulcer that has, they have already desiccated the first toe, and the patient was referred to us much later in the clinic, and we did outpatient care there. We debrided the foot there. This patient, we failed to admit in the ward because initially she was in the ward, and they had removed the toe, and we knew if she goes back for a second admission, the next thing would be, of course, we understand well, angiogram, then we do a below-knee amputation, so the patient also was not very willing to go. We followed them to the clinic, and after 20 weeks, the patient's ulcer was not healed, and we saw a smile in her face. That case again, they won. You can see the dose and part of the food. This guy was at one of the private hospitals in somewhere in Kikuyu, and they needed to do an amputation. He was referred by another patient we had seen earlier, and you see at the dorsum, the fifth toe, of course, is gangrenous, and we certificated the same. Thank God it was the only one that was affected in the dorsum area, and we went on with this guy. After 12 weeks, you can see the last photo, and limb salvage was obtained. This lady from Kitale, Dr. Manutu was seeing her, and they had decided to go for amputation, but he sent them to us. Actually, the last photo that had healed, I don't have it, but later this lady just collapsed, and she went to rest with the Lord. This is another case there. Excuse me. On the plantar part of the foot, this lady, she healed. I don't know where the foot has gone to, but eventually she did. And this is only applying simple basic techniques: time, tissue, infection, moisture, and wound age effect to allow age advancement continuously as we assess. Similarly, this is a case of sharp debridement that we are doing, and this patient was using herbal treatment, and one of the sister brought him to us by force, and we were able to assist in debriding slowly, as I said, basically, and you see the last photo. After the 5th week, the wound had healed. And actually, we were doing cost-effective of wound bed preparation with basic principles. Again, have the right hallers there with the sepsis towards the first metatarsal head, and we did disarticulate that area. Of course, this is outpatient, and you can see the last photo, it healed. And of course, that's the teamwork that we were working with. Again, I'm just showing you pictures so that you can be able to rush with time, and just show you a glimpse that this 80% that is largely preventable probably is true with case series like this one here. And that's the photo at the middle, or the picture at the middle there is just another form of basic offload using just the normal crepe bandage. If you don't have any other gadgets to use, you can use just basic offload, because the wound is on the heat foot, and now you put something there with a crepe bandage, and it offloads, and your patients will heal. Principles and strategies of management. Of course, what we are capturing here is optimal diabetes control. Could be a great principle of managing diabetic foot, and diabetic foot screening so that we can capture them earlier. Lifestyle modification, effective wound care, or rather wound bed preparation is very essential. Of course, factoring infection is very stubborn, and that's where multi-team comes in. Pressure relieving strategies, offload, offload, offload. Offload when we are managing it, offload when they have healed so that we can prevent recurrence, and appropriate footwear. Of course, if possible, we should be able to continuously restore pedal pulses. Factors that are associated with poor foot care practices at times: diverse tradition and culture, self-treatment at home, use of treatment modality, other treatment modalities, social risk factors. And poverty, literacy, and distance is another factor. Specialized practices is one way we need to understand and appreciate. Podiatry services are very essential. Nurses or paramedics should be able to be motivated to do this. And sometimes we are more biased pharmacotherapy approach than applying team disciplinary approach. And now, because of all this, we have a burden. The burden we have here is we have high rates of hospital admissions because of diabetic foot. We have high rates of lower limb amputation and high cost of care. We have physically and emotionally depleted population because of the loss of their limbs or part of their foot. And then we have also the demotivated healthcare providers because of seeing these ulcers for a long time until they really don't see them healing, and they are more devastated, and then reduced productivity is a big burden. Therefore, we need the way forward. We need to appreciate interdisciplinary team specialist approach. Have podiatry and special foot care services, which will be very essential, and develop and motivate expert opinion champions in diabetic foot care, because now, as it is in the country, we have very few or none expert opinion leaders in diabetic foot, and we could do so by improving knowledge transfer into practice. I know many times we go for knowledge, and we have a lot of knowledge and research, but how much do we transfer into practice could be the question. And probably, maybe one of the ways we can do that, we could encourage to have community of practices. And I think in our setups, we have failed to have community of practices so that we can involve all the teams. When I go out for a training like this, I come back to my institution, then I'll be answerable to the committee of practice to be able to see whether we can change the guidelines based on the knowledge that we have gained so that we can have better practice. And also advocacy and implementation of policy implementation. I think we also need to embrace and establish, appreciate partnership so that we can do better in managing diabetic foot. Community health education and a partnership would be the way to go. And I would want to leave you with this thought, wise saying on Isaac, hands on. We need to have passion. Diabetic foot is smelly. It is chronic. It is complex. So you need to have a passion. You need to be committed. You need to be patient, and also work with the patients, showing them that they need to be patient and then have a mission. Because if it's a mission, then we are able to overcome obstacles that come on the way. And we know with wound care practice, good wound care practices will allow the diabetic to keep walking and not tracking as we do. Unless I try very hard to avoid blaming this Kenyan, the blood sugar, the world's greatest scapegoat. That's why the diabetic foot has to be amputated. And for that reason, those who didn't like my photos, please admire the flowers, and thank you for listening to me.
To diagnose the condition, you need to do a lymphoscintigraphy, which is also a very challenging and expensive test to do, not widely available. It is a domain of the cardiothoracic surgeons in terms of management. There are new modalities like lymph node grafting, which are now being looked at. So people, about 2 patients who've traveled to India have had lymph node grafting. But still, in terms of evidence, it's still a very novel procedure. But it's extremely challenging, and it complicates local circulation, complicates wound healing. So very, very challenging if you get lymphedema, especially in the setting of diabetes. But outside diabetes, also very, very common. And also simple things like weight loss, exercise are some of the things that you can use, apart from compression stockings, to try and minimize the effects of lymphedema. Maybe there's a very good question here I think we can ask. We've had a very big problem accessing podiatrists, so this is very good. To Dr. Collis, what's happening in terms of initiatives in Kenya to try and train podiatrists? We have a very big, even Aga Khan ourselves, we don't have access to podiatrists. So how do people who have interest in diabetic foot, where can they get training? Is training available locally?
Thank you, Dr. Jenga. Very good question. We are certainly trying to educate more foot healthcare professionals, in particularly nurses, to manage more of and take a lot of the load off the podiatrists. Podiatry is something that isn't really done here. It's sort of, there's only 3 of us, I think. And the thing is, we need to access more podiatry services. So, you know, most people have to go outside the country to be trained. There is a training school at Witwatersrand in South Africa, but we would like to, that is my next aim. I would really like to sort of, with the Ministry of Health, with the other diabetic specialists, I'd like to set up some form of diabetic foot training, and so that we can train the nurses, because you don't have to be a cardiologist or something to be able to train in the diabetic foot. It just is simple, practical management. And if we could set up the thing and we could start training podiatrists, and we could sort of base it maybe with Nairobi University, have some form of partnership with, say, the UK or South Africa, then we could start bringing podiatry services. Because you cannot have a multidisciplinary diabetic team without a podiatrist. You cannot do it. So if you want to set up a holistic diabetic care center, then you need to basically be able to have access to podiatry services.
Okay, last question from the audience. This is to Fabian and Isaac. In your own assessment, has there been any major change in the quality of foot care in Kenya in the past few years?
Yeah, I think, Isaac and I have worked together for about 15 years now, and yes, absolutely. You know, factually based, we don't have statistics, but, you know, we have definitely impacted in getting the knowledge and information out there to the rural and district areas to basically look at the foot in a much more serious context. So yes, we are changing it, and I'm sure there has been a lot of people who have now understand about diabetic foot management and will be taking it on board. And it's incredibly important. I want to give this to Isaac as well, because he gets out more into the rural areas than I do these days. He still does a lot of these outreach programs. I still do, but Isaac does even more than I do.
Yes, the diabetes foot care is now on the limelight in the country. Several years ago, we didn't have anything about diabetic foot. Kenyatta National Hospital now is a center of excellence in diabetic foot care in the map of WDF and the Ministry of Health. Nakuru, they are doing very well. They have a foot care clinic, and we have nurses there who are doing perfect job. We have Kitale doing perfect job. So there are many centers that have been set. I think we have 3 centers of excellence. Diabetic foot care, Mombasa is one of them, Kenyatta and Nakuru. And then we have 16 centers in the country that are doing basic diabetic foot care. Yes, we could do more when we involve more partners.
Okay. So just a brief background, diabetes self-management education is a key component of diabetes care, and I think we are all aware of it. The main thing is that it's aimed at delaying diabetic-related complications. Most of our diabetics actually succumb or suffer from the diabetes-related complications. And that's what we aim at trying to prevent with diabetes education. So in Kenya, most people are yet to receive this very important component of care. And some of the reasons are because the diabetic educators are few in number. Some of the diabetic educators are located within the urban setup. And also some of our patients do not even know that they need this care. And some of those who know that they need this care may not be able to afford it. So there are a few reasons why they are unable to receive this very important component of care. So at the FMC clinic at the Aga Khan Hospital, the case was no different. Actually, a small audit before this study found out that only 2 out of 10 patients, so 2% of the patients, are the ones who, when referred to the diabetic educators, who in Aga Khan we have them, only 2% would go ahead and receive this care from them. So we wanted to find out the effects of diabetes self-management education in comparison to the usual care that the diabetic patients would receive from their family care provider. So a brief background about what led me in deciding to do this study. Before that is just a brief introduction about what the American Diabetes Association defines DSME as. So this is an ongoing process. It's not a one-time thing. It's something that will continue, and hence the need to develop that patient-doctor relationship that is meant to continue for a long time. And we aim to facilitate knowledge, skills, and abilities important for diabetes self-care. So a few landmark trials had been done before, and amongst them we have the DCCT that was done in 1993 that showed actually intensification of diabetes management would be important in trying to prevent the progression of complications amongst type 1 diabetics. And then in 1998, we had the UK PDS study done among the type 2 diabetics that showed almost the same thing, that intensive glycemic control was important in preventing diabetes or improving outcomes in type 2 diabetic patients. And important to note is that when it comes to intensification, we're not looking at the pharmacological aspect of it only. No, we also look at education, because for the individuals, they need to understand that once they implement these important life skills, that they may be able to manage their diabetes well at home and hence prevent the complications that we are talking about. So it incorporates a patient-centered or a person-centered approach, and this is the niche of us family physicians. Every consultation with a family doctor is more of a shared decision-making type of consultation. So for us, family physician, this was not something very strange for us to do. So, yeah, this is what I wanted to say before that. I had done a background research on a few studies that had looked at this. So Pile et al. In 2015 looked at a population of type 2 diabetics aged 45 to 75. The number of studies involved were 132. And the main findings was that there was a reduction in HbA1c, but although there was little benefit if the contact time was less than 10 hours. But important there was that larger effect was seen with the face-to-face programs. And when it comes to diabetes education, there are different ways that is done to deliver the information. Some of you may be familiar with what we call the conversation maps or group settings, where we are able to take our patients through group-related group education. But for me, I wanted to look at that face-to-face intervention. So that's one of the reasons why I chose my study the way I did. And then Steinsbeck et al. In 2012 looked at a different population. These were 21 RCTs, and they actually noted that in 6 months there was a significant HbA1c reduction. So as I mentioned earlier, I did this during my residency. Time was a limiting factor, but I thought that looking at my intervention over that 6-month period would still show me some results if there were any, and time in itself would not be per se such a limiting factor. Okay, so in terms of the design, setting, and participants, we conducted an unblinded randomized clinical trial among suboptimally controlled type 2 diabetic patients attending the FMC clinic at Aga Khan Hospital. It was hard to blind the providers. I mean, every provider knew that this person was part of the study, so we found it a little bit hard to blind the providers. And even the patients themselves, for those who are receiving diabetes care from the certified diabetes educator, they already knew they were part of the study. So this, we found it hard to blind the providers and the patients as well. So the study population, we have a family medicine diabetes registry that we are able to record all the diabetics that come to the clinic. So that is what I used. I recruited and screened patients from that. And what I looked at were the suboptimally controlled type 2 diabetics defined as a HbA1c anything above 8%. I also looked at that age 18 to 65. I didn't really want the extremes of age, of course, to avoid any complication that would come from intensification. So we excluded other types of diabetes, included type 1 GDM. We excluded that, as well as diabetes-related complications. I'd say this was actually a little bit hard to do, but we went through the records and we looked at their last UECs, trying to exclude any nephropathy. And then we also looked at their last eye checkup. Most had not had an eye checkup, so I'd also say it was a little bit hard. But for those who had, we just wanted to make sure that they did not have any retinopathy, as well as clinical notes from their family physician to make sure that there was nothing like any neuropathy that had been recorded or any features of other complications. And of course, anemia, the last hemoglobin count, just because we know that anemic patients have short-lived RBCs, and so would likely test falsely for the A1C level. So the intervention was diabetes self-management education by the certified diabetes educators, plus usual care from the family medicine doctors. So DSME was done as well as the usual care they would receive from their family physicians. So a bit wordy, but I thought it was very important because this is where the differences come in. What was usual care? Yeah. So usual care by the family medicine physician was delivered as per their usual consultation. So as I told you, patient-centered approach is part of what we do, not only amongst diabetics, but among other patients who are suffering from chronic illnesses. So that's what we did at the FMC with no modification. So important also to note that usual care was not standardized. We had 3 family physicians involved in this study who are the major doctors at FMC who would see the diabetics, and we didn't really try to standardize what they were doing. Everyone saw their diabetics the way they would. So it entailed a 20 to 30 minutes standard doctor's consultation, where we did what we normally did. We reviewed their last A1C level. We checked for their medication, what they are taking. We checked for compliance. We reviewed their medication. If some need to be titrated upwards, we did that. And then we also offered them a brief, informal, patient-tailored diabetes education. And then, of course, we scheduled them as per usual, the 3-month follow-up. We would rarely give them longer follow-up periods because we noticed with that, some would be lost to follow-up. So we also gave them what we would sometimes give them. That would be the print, audiovisual, and online patient education materials, depending on the providers and also depending on the patient. You realize that different patients would have different requirements on that consultation. Maybe they had read something about a new modality of treatments, and so maybe that's what they were concerned about. So we would really tailor the consultation based on the individual patient needs at that point in time. So for the intervention, this was the diabetes self-management education. So they received the usual consultation from the family physician, but they were also referred for an additional education by the certified diabetes educator. And so as I had said, this was face-to-face, it was individualized, and the kind of model of teaching they used was an empowerment, just trying to empower them more towards doing the different behavioral modifications to try optimize their sugar control, as well as looking at other ways they can solve their day-to-day problems that they meet at home. Yeah. So the education content involved the 7 core self-care behaviors according to the AADA, that's the American Association of Diabetes Educators. And this involves being active, nutrition care, how they can monitor their blood glucose themselves at home, and then adherence to medication, amongst other topics. The participants were scheduled to attend 3 one-hour sessions, and the 1-hour sessions were after every 6 weeks, just trying to cover the 3-month period. And then what additionally we did, we tried to remind them through phone calls, and then there was also a hotline number availed to them in case they needed to talk to the diabetes educator. And I'd want to add that this is part of the normal practice that the diabetes educators do at the Aga Khan University follow-up. And then, after their session with the diabetes educators, they were scheduled to continue with their regular follow-up with a family physician after every 3 months. So what were we looking at? The primary outcome was the HbA1c level, and then we also looked at the blood pressure as well as the body mass index as part of the secondary outcomes. So what did we find? So I hope this is clear, but if not, we had 220 patients that I was able to retrieve from the diabetic registry, but only 140 of them underwent randomization, 70 in each group. Unfortunately, this study had a significant amount of patients who are lost to follow-up, and this were around 31%, with only 55 being assessed for the final visit in the intervention group, and 41 patients out of of 70 being assessed for the usual care group at the end of the 6-month period. Okay, so some of the key things I wanted to highlight from my patient population, that the mean age was 48, around 48.8, so 48, 49 years of age. Most of my patients were male, and I'd say this was quite hard even to encourage them to keep on coming for the hospital visits. And the mean HbA1c amongst all my patients was around 9.9. The duration of treatment seemed also to have been a bit short. Most of my patients were 5 years or less since they had been diagnosed with type 2 diabetes. Okay, so these are the main findings. So we look at the mean differences of the primary and secondary outcomes between both groups at the end of the 6-month follow-up period. And the key things were that in the control group, we had a 0.6% reduction in the HbA1c. And the control group is the usual care group. And then in the intervention group, slightly higher, 0.97% reduction in the HbA1c, but the p-value was not statistically significant. And even amongst the other secondary outcomes, the p-value was not statistically significant. So, yeah, now this is where the rubber meets the road, because this study, I'd say, recorded a negative outcome from what we had expected it to. And I looked at a Cochrane review that was done in 2009, and it almost showed similar results because they looked at results done over the 12 to 18-month period, and it reviewed